Good morning. We've actually had one astounding lecture, and I think we are actually about to have another. It's my pleasure, in my capacity as the chairman of the BJS Society, to introduce this year's BJS Travelling Fellow. The BJS Travelling Fellow is an individual who annually, on behalf of the association, undertakes, I guess, what one might actually call some form of external audit. Our speaker has been travelling furiously across Great Britain and Ireland to gather data and is going to give us insight into what we think we are actually doing. And it is always a lecture that is well anticipated at this association. The BJS Society has got a long association with ASGBI. It supports this travelling fellowship, the Moynihan Prize, the John Farndon Prize. The journal itself is about quality. This travelling fellowship does attract quality, and this year's speaker is no exception. I'm not going to repeat the achievements of Dorry Segev, who's going to speak to us just now. He is based in Johns Hopkins University, which, for anybody who's not actually travelled to the States will know that that actually is the hub of surgical excellence based in Baltimore. Dorry has been looking at various aspects of transplantation. He himself is a pioneer. You might think it's difficult in this day and age to be a pioneer in transplant surgery, but he has done a number of, or undertaken a number of world firsts and American firsts in transplantation. He has expertise in a number of areas, and we are really grateful to him for spending his time. We know that he's actually already been well abused at this meeting, but we are very much looking forward to this particular presentation. So, Dorry, you're most welcome.
Thank you to the organizing committee for making this opportunity possible, and for that warm introduction, and thanks to the BJS for supporting this. So I've spent the last 10 days or so traveling about the UK. This photo is an example of what happens when you arrive jet-lagged. Then you get to see the 5 a.m. sunrises. I've visited a number of centers across the UK. I've had the opportunity to meet with transplant surgeons that I've met at conferences and see where they work and the environments that they work in. Obviously, I had a chance to take some photos of some beautiful places in the UK and to enjoy the various and colorful languages spoken in the UK, which strangely are all referred to as English. I started at Oxford, and I'd like to thank James Gilbert for his hospitality there. I moved to and at Oxford, I also had the pleasure of meeting the Corel Club and discussing training with these folks. I moved to Birmingham and was hosted by Darius Misra. My thanks to him. Then to London. First, I visited the Royal Free Hospital there with under the hosting of Bimbi Fernando. Yes, I did take this picture. I'll let you figure out how. And then off to Guy's Hospital, hosted by Nizam Mahmood, and thank you to him as well. To Newcastle, I only had my cell phone there, so that's the only photo I have of Newcastle. And thank you to Derek Manis, who actually planned sort of all of my visits across the UK. And if you saw my itinerary, you would understand why I've nicknamed him Derek Manic. And then finally to Edinburgh, and thank you to Lorna Marson for her hospitality in Edinburgh. And what I'll try to do is, so that the charge I was given, the questions I was given to answer regarded the potential use of telemedicine in transplant centers in the UK. performance evaluation specifically with regards to individual surgeon evaluation, and then transplant training with the charge of comparing training in the United States with that in the UK, and sort of helping advise the next phase of transplant training in the UK. So we'll start with telemedicine. For each of these topics, I'll sort of give you an overview of why transplantation is unique among general surgery in the use of these, in these particular areas, and then what I've discovered across the UK and some perspective. So transplantation is unique with regards to telemedicine because we have lengthy and difficult evaluation of patients and lengthy patient education. So our patients don't just need to know that they're coming for a hernia, they need to know how to accept organ offers, how to seek for live donors, et cetera. And all of the education that we give them initially is generally not enough. We have long-term relationships with our patients, even our living donors, as opposed to sort of the one-time off elective surgical operations where you send them back to where they came from. Here, basically, anyone we transplant, we effectively marry, and we actually, unlike marriage, we actually follow them for life. Most people don't want to touch our patients, so ours are the scary patients. They're on immunosuppression, they're on more steroids than most physicians are comfortable with. Their abdomens are complex, and so usually, sometimes pre-transplant, but especially post-transplant, we end up doing the general surgery on them as well, and so that makes us unique in the follow-up. There are paradigms of care, and we're shifting from sort of this hospital-based paradigm internationally to more clinic-based paradigms, and then even this concept of the between visit. And I think that most of telehealth will rest in the between visit paradigm, or maybe even out in the community of care paradigm, where there's less complex visits arranged, and these are the least costly paradigms of patient care. What are we seeking? We're seeking something like what University of Cincinnati has put together, and my thanks to Shim Shah for sharing some slides with me. They involve telehealth in multiple domains, both pre-transplant and post-transplant. For the pre-transplant, they've prepared educational videos, so in addition to the patient coming in and being evaluated, there's so much education that the patients require that they just take this online, and the patients can go home and watch a lot of educational videos in the comfort of their own homes. And then they ask their patients if they attended the class when they were listed, and if they watched all the available educational videos. You see 95% of their patients have watched all of the educational videos, and in fact 65% have watched it more than one time. So these are very useful uses of technology. They also in Cincinnati have really gone the next step in post-transplant home monitoring. They give their patients devices. They noticed that most of the health care of their patients occurred between hospital visits, between clinic visits, and so they really wanted to sort of remain engaged with the patients during that phase of things. They have a triage nurse that monitors the patients. They actually have devices that the patients wear, things that attach to their smartphone when they can get glucose monitors and things like that, and these are all transmitted back to the center. They set up a tablet at home. They attach that to a blood pressure monitor, to a glucose monitor, et cetera. They can communicate even in a non-in-person visit. So for example, the patient might say, hey, I have a bump on my incision. They get up on their tablet, they aim their tablet at their incision, and the surgeon in the center can actually visualize it. It's not exactly the same as physical examination, but here's on the bottom right, there's the patient getting sort of feedback on whether they've put their VAC wound dressing on properly. And then they can also use this to manage medications and things like that, so they attach the home monitoring to electronic pill boxes. They published their first series where out of 23 patients that they offered this to, 20 of them were enrolled, the 3 excluded for various reasons. They got a home visit to set everything up. This is an example of how the values that they identified with a blood glucose monitor. So you see they're identifying a lot of outliers for their patients that they can monitor. And in doing so, in their original pilot, they reduced readmissions by about 20% and estimated that they saved themselves about $150,000 in a very short period of time for only 20 patients. So this is sort of the ideal goal of telehealth. I got some great slides from Joe Henry from the Royal Free in London on the development of web-based video learning tools here in the UK. The sort of motivation for this was that education was based on face-to-face learning during a few short appointments, and that was not retained and that was not sufficient. And so they've created these videos, and they've used the fact that all NHS buildings have prioritized Wi-Fi, whether it's reliable Wi-Fi or not. I heard various stories across the UK. But the aim was to provide patients more education through these videos. Videos were designed to be short and to focus on explanation and understanding of transplant lexicon, potential issues that they would face, etc. And they were structured according to marketing principles, so attention, retention, edutainment, as they call it. And this is just a screenshot from one of the videos at the Royal Free. So some of the pre-transplant education is being done here through this technological type of thing. So we could call it tech health rather than necessarily telehealth. On the follow-up side of things, this is an example from the renal community. So the kidney community has this renal patient view, which allows patients to actually log in and see their laboratory values. And this gets used in dialysis patients, but also post-kidney transplant patients. And again, another screenshot from patient view where they can see their health records. They can access it on their mobile. They can enter results. They can monitor results, etc. In talking to people, there are advantages of this because this has reduced patient inquiries to the secretaries calling and saying, hey, I got my creatinine checked this morning, can you tell me what the value is? And they feel engaged, they feel like they've sort of taken ownership of their post-transplant course. And some patients like actively checking it, and in fact, some patients discover their creatinine values before their providers do. The disadvantages is that there are still a lot of calls being generated now sort of on the other side of things to say, hey, I logged into patient view and I saw my creatinine went from whatever it is, the values that you use, from something to something slightly higher. Sorry, I don't have a good sense, from 110 to 111 or something. And now the nurses have to pick up the pieces of this and sort of explain to the patients that this is actually okay, or to react on these things. And the provider still has to monitor the results, so some disadvantages, but the patients who use patient view seem very, very happy with this because they feel like they're much more engaged in the process. I heard a little bit of telehealth being performed through social media. So apparently a lot of patients, particularly those of the demographics that use social media, are using social media to talk to other patients post-transplant. And I heard from some units that they had nurse practitioners create professional Facebook profiles and join these Facebook groups to sort of keep tabs on their patients, make sure that there isn't weird information being distributed, and to learn more about what's going on with their own patients. The most remote, the sort of most common example of remote health that I encountered was collaboration between local GPs and the transplant units. So for example, the transplant providers will go to a remote area and conduct an evaluation clinic in person, and then the pre-transplant and post-transplant management is done by the local GPs or nephrologists or hepatologists, but in collaboration with the center. And the center will use technology then to communicate with the local providers, have a weekly multidisciplinary meeting involving the local providers, not for necessarily direct interaction with the patients, as the Cincinnati example that I gave you. But some have used a sort of modified telehealth for interim assessments. So The patient is seen in the transplant unit for follow-up visits, but between these visits, you can't see them 3 times a week. It would be a bit crazy. The blood work is done by their GP, and either the transplant center reviews the blood work with the GP, and the GP reports this blood work and the corrective actions to the patients, or the transplant center then just receives the blood work that the GP has been kind enough to draw and run, and then communicates directly with the patient by phone. So it's sort of a telephone health to save them from coming in person between their things. There was one recent report of Skype clinics after intestinal transplantation from the group at Oxford that I wanted to showcase. This is their recent publication on this, and they're actually doing Skype clinics, and their motivation is, rather than having their patients, so they're doing intestinal transplantation and drawing from all over the UK. This was an estimate of number of miles that patients have to travel to their center from the various islands and highlands across the UK, and for these patients who have to travel 500 miles, it seemed most convenient and most expeditious to actually do clinics by Skype. So the same way you would do a clinic, but your patient is phoning in by Skype. The advantages of a Skype clinic, obviously, is less travel for the patient. This is very good for remote patients or for patients who are busy and don't want to spend their day traveling, although on the counter side, many are not employed and actually enjoy their day, spending their day traveling to the transplant center. Less expensive for the NHS and for the nation, and is sort of a greener option. The challenges are the connectivity, so the IT at the units or the IT at the patient's homes or boat houses. The patient feels better actually if they come in person. They feel more connected to the transplant staff. They feel more reassured that somebody looked at them. I heard that patients sort of wanted to compartmentalize their life from their disease, and they wanted to leave their disease at the hospital, so they feel more comfortable coming to the hospital for this care rather than dealing with it at home. And some really love the clinic, and if there's an issue in the clinic and somebody's not there to staff it, they'll wait for hours to see their provider. Some language barriers are best handled in person. There was a reimbursement tariff commission kind of issue. Will we get paid enough to do exactly the same work that we would do in a normal clinic, but now over Skype? The classic clinic is the most efficient for the doctor. You show up, you have your 3 hours, you see patients one after another. You're not quite aware of the chaos in the waiting room, and you don't really care about that chaos. You're seeing your patients. And is it safe to actually care for people over Skype? Are you going to miss things, and whose responsibility is it if you miss things over Skype? And then there's another issue here in the UK, different from the US. In the US, if we send somebody for a creatinine, we just send them to a local laboratory. They go in, they get a needle stuck in their arm, and they do the blood test. Here, the testing paradigm seems to be much more that the tests are either done in the hospital or are done by the GP, which is a different paradigm that would then make independent testing with an independent Skype clinic a little bit more challenging. One really nice example of what's going on in the use of technology for sort of remote health is the NORIS system. This is the National Organ Retrieval Imaging System, and this, because, I'll tell you a little bit more later about this, but because retrievals are done based through retrieval teams, if you're sitting in Birmingham waiting for a liver and the team at Oxford is recovering that liver, then you can get images of the liver and information about the liver over your mobile, and so that helps people make intelligent decisions about organ acceptance, and that's a really nice use of technology. To switch gears a little bit to performance evaluation, and remember my charge was specifically performance evaluation at the surgeon evaluation level. So, is transplant ready? Is it applicable for moving from team-based evaluations to individual surgeon evaluations? Again, transplantation is unique with regards to performance evaluation. In transplant in the UK and the US, there are more data systems available than most general surgical specialties because we have donors and we have to make donor offers, and so we have data on the donors. We have a waiting list, and so we have data on the people who are on the waiting list. We have post-transplant information because we have data on who accepted which organ, et cetera. Both US and UK have active regulatory environments. Another unique thing about transplantation is that you're dealing with a national resource, not just money, but organs, and organs have to be distributed fairly. And so it makes sense then that you don't want an organ going to a unit that doesn't know what to do with that organ. And the other unique aspect of it is that it's a team sport, and sometimes the patient might not even know who will operate on them on the day that they're being evaluated, or might not even know who did operate on them post-transplant, because 3 people may have been involved in doing the operation, and then 2 days later somebody else is on service when they're out of the ITU, and the person they meet is not one of those 3 people. And the other unique aspect of it is that there aren't many transplant centers here. There are 23 kidney units, 7 liver units, and this comes into play with what we do with performance evaluation. The NHSBT was kind enough to share with me some information about what does get monitored. There's been monitoring for years, and in the last recent years, there's been risk adjustment to these monitoring. Graft failure, patient mortality is sort of the theme. When we think about the regulatory environment, so I'll just kind of step back philosophically for a few minutes. If we have full autonomy and we're totally unregulated, well, then we do what we think is the right thing. And if things didn't go well yesterday, we learn from them today. And that's sort of clinical practice evolution. And if things aren't going well today, well, we'll make them better tomorrow. And that's innovation. And in 50 plus years of doing this in transplantation, if you look at published outcomes from transplantation across the world, every year outcomes get better, actually get better without any, even way before any of the regulatory environment. So what we do is actually for the care of the patient. Why should there be regulatory pressure? Well, the questions to ask with that regard are, what benefit comes from regulatory pressure? What are the unintended side effects of regulatory pressure? Who is at risk for these side effects, and to what extent is the risk, and is the benefit we gain from regulation worth these side effects? Again, in the context of we already have a very self-regulating environment. When the pressure increases, the consequences change. And so if this is self-regulation, well, then the consequences of self-regulation might be depression. So you realize that you're not doing very well and you've had a patient die, and this causes you to lose sleep. If you are presenting at a departmental morbidity and mortality conference, the department might see your bad outcomes, but that's not so bad. They know that you're trying your best. If it's a community regulatory environment, then your peers see your bad outcomes, and so there's a little bit more pressure associated with that. But when it's the government involved in this, you're risking getting your center shut down, and in the US there are centers being shut down for poor outcomes, and so that's a huge regulatory pressure on somebody. And the more severe the consequences, the better the system for identifying centers with bad outcomes needs to be. Because if your system is, we pick up some people, we have some false positives, and it's just internal, then that's one thing. You can realize it's a false positive. If you're publishing this on the internet and you're risking getting your center shut down, and the system is terrible at identifying who's good and who's bad, that's highly problematic. If the system is not good, in fact, but the consequences are severe, then risk-averse behavior ensues. And that's what we all kind of worry about with the regulatory environment. In transplantation, risk-averse behavior relates to being selective with patients and then being selective with organs. And so we deny transplantation to people who we know will benefit from a transplant because they have a scary phenotype, or we turn down organs and put them in the rubbish bin, even though we know that that organ would have helped somebody because, again, it's a scary organ that brings with it some risk. And some of these types of restrictions, this risk-averse behavior, is misled. And we just talked in the transplant session about how we can get misled by these things. Some of it is clever by understanding the system and realizing that this person actually makes you at higher risk. But both of these types of restriction are natural in a regulatory environment. And in the US, when people get flagged, their volumes drop. So they get flagged, they get scared, they stop doing transplants. One of the big issues in the UK, as I was talking to people about, was what are you even going to regulate people on? Thank you to Steve Wigmore for sharing some of his slides. Are you going to regulate people on death, graft failure? When? 30-day, 90-day, 1 year? What kinds of death? Or are you going to look at the consequences of not transplanting somebody? So obviously, if you deny somebody a transplant and they have a high MELD score and they're a liver candidate, then they're going to die very quickly. And is that really better than than transplanting them, but with a slightly higher risk? Opening the highly rated academic journal of the UK, the Daily Mail, can show you multiple articles about what happens when you start to publish individual surgeon outcomes. And so here they listed surgeons who were who had mortality rates of 30-fold higher than the national average, again, without an explanation of, are these people taking on higher risk, or are they actually just showing worse outcomes, or did they only do a handful of operations, and so the confidence interval is quite wide. And the pictures are shown, and the mortality rate increase is shown as well. So this is scary to us that we might have our picture on the front page of the Daily Mail if we have one too many deaths. On the flip side of that, there is huge advantage to understanding how well you're doing in the operating room. This is a really beautiful study by Birkmeyer and his colleagues at Michigan, where you're all probably familiar with this, they took the videos from laparoscopic gastric bypasses, anonymized them, sent them back to the same surgeons who were in the study and said, evaluate these on technical excellence, and then they got a technical excellence score, and those that were in the bottom quartile of technical skill, purely technical skill, had much higher surgical and medical complications than those who were in the top quartile. So, our operative skill actually matters. And if you can go back to these people and say, everybody who watched your video thought you're slow and clunky and don't know how to do an anastomosis, then people might seek coaching to improve that. I talked about transplantation as a team sport. This is a nice slide from Steve Wigmore showing all of the people involved in a single liver transplant, from the ones who listed the patient to the ones who took the organ offer for the donor to the ones who actually did the donor operation, the ones who backtabled the liver while the other consultant was opening the patient and doing the hepatectomy, the ones who sewed in the liver, the ones who took care of the patient in the ITU for the very first couple critical days post-transplant, and then the one who managed the patient for the 2 weeks afterwards. And if there's a death, who's to blame from this team sport? The issues with individual surgeons and transplantation, with individual surgeon performance evaluation, is we have multiple surgeons doing the back table, the donor, the postoperative management, and so it's hard to find blame for an individual surgeon. And there was another issue that was raised that was interesting to me, is that our whole enterprise depends on trust. I do a pancreas transplant. If I'm doing the back table, the person doing the patient side trusts that my back table will be fine. And if he's now starting to get evaluated for his individual outcomes, he might say, you know what, you're a nice guy and all, but I don't trust you to do the back table. I have to do the back table myself. And then we have this person now wants to also do the donor themselves. In the US, liver transplant centers fly out across the country to go get livers that they're going to implant because they don't trust somebody on the other end to do the recovery. The entire national organ retrieval system that you have here in the UK would entirely fall apart if we were now, the person sewing it in were responsible for what the organ retrieval team did. And so that's another issue. I asked people the question, so what if they forced you to be evaluated? What if you needed some sort of evaluation? How would you evaluate it? And one thought was to evaluate the non-transplant operations that transplant surgeons do, or to look specifically for surgical outcomes like blood loss, time for various parts of the operation, especially time for the anastomosis, whether they need a reoperation for bleeding, early arterial thromboses, et cetera. But again, with all of the individual surgeon things, there's already a system in place. There's Morbidity and Mortality Conference. We talk about the problems that we have in the operating room with our team, and usually the problems are discovered by the team and they're dealt with by the team. And if you want to actually sort of rehabilitate somebody, they have to have the buy-in of the team. And then the last issue of individual surgeon performance evaluation was the subjective things, which I thought was interesting. So how do you evaluate communication, the environment in the operating room, the bedside manner, the judgment of the individual, their ability to work as a team? Because if these are flawed, then the entire team falls apart and the care of the patient falls apart as well. And these are actually more difficult to evaluate. Again, from Steve Wigmore, what worries surgeons is case mix variation, a run of bad outcomes, a change in performance or circumstances, and then misrepresentation of data to the public or peers. And so until we can get the system right where we feel comfortable that what goes out there is really what we're all about, then that's a risky endeavor. You know, the advantage of the Berkmeyer study is that they anonymized the videos. They watched people doing anastomoses. They sent it to 30 of their peers to rate. And look, if 30 of your peers thought that you're slow and clunky, you're probably slow and clunky. But releasing your 1-year survival, is that really going to reflect what you've actually done? Bimbi Fernando shared with me some slides of a presentation to their MDT that actually listed out the individual surgeons, not by name, but by number, and that caused the most barbed discussions in terms of the entire multidisciplinary team and their view of who is doing these operations. And this was just a simple 4 surgeons. This is the percentage requiring no transfusion. You see surgeon 2 has a much lower percentage of 0 transfusion transplants. And then similarly, surgeon 2 has sort of the highest length, the longest length of operations, particularly in stage 1. Does this correlate with outcomes? This seems to correlate a little bit with some of the early outcomes that could be measured. But again, you know, how do we take these data and help surgeons improve without making people feel risk averse is a challenge. And some of the units are starting to do this internally. When thinking about performance evaluation, I'll kind of end this section on this thought. The key is sort of ranking versus competence. And so if we are ranking people, what do we do with the rankings? What if imagine we shut down the worst liver center every year? In 7 years, there'd be no liver centers. So is that really what we want to do? Do we really want to take people and say, you are the best transplant surgeon in the country, you are the worst transplant surgeon in the country? Do we rank Nobel Prize winners? What if we said, this is the dumbest Nobel Prize winner in the history of the world? I mean, that person's still pretty damn smart. And so the worst transplant surgeon in the country is probably still a fairly good surgeon and maybe just needs a little bit of coaching. Maybe what we should be doing is flagging internally for competence. We can use the same metrics, but if we flag for competence, then we would take that flag and turn it into peer evaluation and coaching, etc. The last topic I wanted to talk about was transplant training. So I was asked to sort of look at the difference between US and UK training and make some recommendations. Again, transplantation is unique in terms of training. Many transplanters also do general surgery. Transplantation, these are complex and technically different operations. Some operations are even 2 or 3 consultant operations. And so then how do you bring a trainee into this mix? The patients are complex. We operate on healthy donors. And how do you allow a trainee to then put a donor at more risk than you know an experienced consultant will do? And we have heterogeneous practices, so some people are doing liver, some people are doing kidneys, some people are doing both, etc. This is sort of the overview that you all know well of general surgery training in the UK. Again, thanks to Bimbi for sharing this with me. And I suspect that the red things here are, these are the things that are general surgery related. And there's a lot of requirement for general surgery throughout the 8 painful years of training and very little opportunity to really seek transplant specific training. If you think about the last 2 years, the 7 and 8 years, and you assume that somebody's going to seek as much transplant training as they possibly can, go up to 56 hours per week, take only 6 weeks of annual leave. Do you guys really take 6 weeks of annual leave? We get like 4 days. Then your training time is 5,000 hours, but it takes 10,000 hours, as we know, to make somebody an expert. So there's not a lot of opportunity to really get good transplant training here. This is the different specialties in transplantation. the various things that you need to master in order to truly be an overall transplant surgeon, and is this realistic within 2 years, or do we really need to go farther and add fellowship like we've done in the United States? Training in the UK for transplantation is heterogeneous. Some use fellowship to supplement their training. Some use it to wait for a job. Most don't even get fellowships. There's no indicative required numbers for each operation, unlike what we have in the US. And then there's another concern that with less exposure to transplantation in the general surgery years, how are we even going to recruit people into the field? In the United States, the ASTS has requirements. If you're going to be a transplant surgeon, you have to have done this number of each of these organs if you want to be credentialed for that organ, and you have to follow the Academic Universe, which is a tech-based online training system. Numbers are important. This was shared to me by the Guy's Hospital crew. You see here the length of an operation of a hand-assisted laparoscopic donor nephrectomy. The first 45 or so, much longer operation in the early part of the training. Then the operative times get pretty good, and then there's a little blip there when you take on the next trainee. Here's the next trainee that came into that surgeon's hands. They had long operative times initially, then they got sort of more consistent and more reliable, and then they took on a new trainee and operative times went up as well. So there is a learning curve in what we do. In addition, there's sort of a didactic component. The ASTS has an Academic Universe online modules that every fellow has to complete in their entirety, because we know some fellows, if they come to Hopkins, will see 100 incompatible transplants. Some fellows, if they go elsewhere, might see 0 incompatible transplants. They still should understand the science and biology of all of those things. I think the most impressive example of formalized training here in the UK, which you then may try to take and generalize to full transplant training, is the training of retrieval teams through NORSE, the National Organ Retrieval Service. And this I found to be, really impressive, organized way of training people, where if you're going to be a consultant for the NORSE, it involves many steps, including attachment to a transplant unit, registering with the NHSBT. There is a huge learning pack associated with NORSE training, with all of the documentation that's required and all of the assessment that's required. They've used e-learning, so there are e-learning modules, for abdominal modules and cardiac modules. There's a surgical masterclass, which again, they have to be involved with. There's experiential training where you develop skills and progression, and you are being monitored through this experiential progression. A 360-degree assessment with a provider that sort of follows you through this. A retrieval assessment assessed by your own unit, and if they sign you off on this retrieval assessment, they're willing to take responsibility for whatever you do to organs that get retrieved by your unit, and certification is issued by the NHSBT. And this, to me, sort of is a really good framework for how we can think about training somebody in a very formal way that takes advantage of technology, that takes advantage of what we need in terms of individual mentoring in the operating room and individual sign-offs and observation. So again, I'd like to thank the BJS for making this possible. I'd like to thank Derek Manis for providing the interesting questions about telemedicine, performance evaluation, and transplant training, and hopefully I've reached you to a slightly higher level of enlightenment. And this is one last shot from Oxford looking at the English countryside. So thanks again for the opportunity to visit.